Welcome to the deep dive. Today we're focusing on a really crucial topic for your MSRA revision, chronic limb ischemia, or CLI.
That's right. It comes up a lot.
Exactly. So we've taken a whole set of detailed notes and basically distilled them down. Our mission here is to give you a really clear, high-yield overview.
We'll cover it all: definition, causes, risks, how it works, what else it could be, the whole picture.
Right through to investigations, management, prognosis, complications, the lot. We'll even throw in some memory aids.
Yeah, because medical info can feel, well, overwhelming sometimes. We want to simplify this.
Make it stick. So let's get started. In simple terms, what exactly is chronic limb ischemia?
Okay, so at its core, CLI is basically a serious reduction in blood flow getting to the limbs, mostly the legs.
And that's usually down to vascular disease.
Primarily, yes. The main underlying issue tends to be vascular disease, especially atherosclerosis, that buildup of fatty plaques in the arteries.
So it's strongly linked to peripheral artery disease, PAD.
Absolutely. CLI is essentially the severe end of the PAD spectrum. Often, you'll see earlier PAD presenting as intermittent claudication, that pain when walking, as a kind of warning sign.
Okay, so atherosclerosis is the fundamental problem. But what actually causes that in the context of CLI? Are there other contributors?
Well, atherosclerosis itself, the plaque buildup, is the direct cause of the narrowing. But other things can play a role or worsen it. Think about thromboembolic disease, a clot traveling and lodging there, or sometimes vasculitis, inflammation of the vessel walls, even occasionally something physically compressing the artery.
But the big picture is those risk factors driving the atherosclerosis.
Exactly. Those common risk factors are what really pave the way for the plaque to develop in the first place.
Let's nail those down then. Who are we most concerned about? What are the key risk factors for CLI?
Okay, there are several major ones. A good way to start remembering the most common ones is the mnemonic SAHOF.
SAHOF. Okay, what's that stand for?
Smoking, age, particularly at advancing age, diabetes, hyperlipidaemia, so high cholesterol, obesity, and a family history of PAH.
SAHOF. Smoking, age, diabetes, hyperlipidemia, obesity, family history.
Got it. Those are the real big hitters.
Yeah.
But you also need to keep in mind things like chronic kidney disease that can accelerate artery calcification, and maybe some autoimmune conditions that cause inflammation.
Good point. So SAHOF covers the main bases.
Yeah.
Now, can you walk us through the pathophysiology? How does this actually happen in the body?
Sure. So it starts with that atherosclerosis process. Plaque builds up inside the arteries supplying the legs.
Narrowing the pipes, essentially.
Precisely. This narrowing, or stenosis, restricts the amount of blood that can flow through. When the leg muscles need more oxygen, like during exercise, the narrowed artery just can't deliver enough.
And that causes problems.
Yes, that mismatch between oxygen supply and demand leads to tissue ischemia. The tissues don't get enough oxygen or nutrients.
Which leads to
Pain initially, like that claudication pain. It also means wounds don't heal well. And if it gets severe enough or goes on long enough, you get actual tissue damage, maybe even tissue death.
Okay, reduced flow, tissue suffering. Makes sense.
Yeah.
Now, if someone comes in with leg pain, it might not always be CLI, right? What else should be on our differential diagnosis list?
Oh, absolutely crucial point. You need to think broadly. Firstly, PAD itself is on the list. CLI is just the severe end.
Right.
Very importantly, you must differentiate it from acute limb ischemia. That's a sudden blockage, a surgical emergency, completely different urgency.
Okay, acute versus chronic, big difference. What else?
Deep vein thrombosis, DVT, that causes leg pain and swelling too, but it's a vein problem, not an artery problem.
Different system.
Yeah. And then you've got musculoskeletal things like spinal stenosis causing nerve pain down the leg, or arthritis, things that can mimic claudication pain.
So carefully distinguishing is key.
Got it. What about how common this is? What's the epidemiology like, say, in the UK? In the UK, estimates suggest CLI affects maybe 1 to 2% of the population.
That's quite significant.
It is. And the key thing is the age link. Prevalence really climbs as people get older. We mentioned that AA and SAD-HOF advancing age, it becomes much more common in the over 70s.
So definitely something to keep in mind, especially with older patients presenting with leg issues.
Okay, so how does CLI typically present? What are the clinical features we should look for?
The classic starting point is intermittent claudication. That's the cramping pain, usually in the calf, but can be thigh or buttock, that comes on reliably after walking a certain distance.
And gets better with rest.
And gets better quickly with rest. The memory tip, pain on the pavement, is pretty good for that.
Pain on the pavement. Like it. What happens as it gets worse?
A really worrying sign is rest pain. This is persistent pain, often burning or aching, typically in the foot or toes, and it's often worse at night when lying down. Gravity isn't helping pull blood down then, you see.
Right, that sounds much more severe. Other signs? Definitely. Look for physical signs. Non-healing wounds or ulcers, especially on the feet or ankles. The affected limb might feel cold compared to the other side, and crucially, check the pulses. They might be weak or completely absent in the foot, dorsalis pedis, posterior tibial.
And in the really advanced stages.
Then you might see signs of actual tissue death like gangrene, blackened toes, or parts of the foot. That's critical limb ischemia territory.
Okay, pain on the pavement for the early sign, then rest pain, ulcers, coldness, weak pulses, and potentially gangrene.
Got it. So if we suspect CLI based on these features, how do we investigate?
Well, the history is your first big clue, that story of pain with exercise relieved by rest. But the key objective test is the ankle brachial pressure index, the ABPI.
The ABPI, tell us about that.
It's straightforward, really. You measure the systolic blood pressure at the ankle and compare it to the systolic pressure in the arm. You get a ratio.
And what do the numbers mean? So a normal ABPI is generally between 0.9 and 1.2. If it's above 1.2, that can suggest the arteries are calcified and hard to compress. You often see this in patients with diabetes or chronic kidney disease.
Okay.
An ABPI between 0.5 and 0.9 suggests mild to moderate PAD. But if it's below 0.5, that indicates severe PAD, and that's highly suggestive of CLI.
Below 0.5 is the critical number for suspicion of CLI then.
Generally, yes. Though remember, some conditions like certain vasculitides, maybe Berger's disease, can cause claudication symptoms sometimes with a normal ABPI, especially early on.
Right, so ABPI is key, but not the only factor always. What other tests might be useful?
After the ABPI, Doppler ultrasound is often the next step. It helps visualize the blood flow directly and can pinpoint blockages or narrowed areas. It's non-invasive, readily available.
Good first-line imaging then.
Yes. For more detailed anatomical mapping, especially if you're thinking about intervention, you might move to CT angiography, CTA, or MR angiography, MRA. These give really good pictures of the arteries.
And invasive angiography.
Invasive catheter angiography gives the gold standard images, but it's usually reserved for when you're actually planning a procedure, like stenting or bypass, because it carries more risk.
Okay. And what about blood tests?
Oh yeah, essential for looking at the underlying risk factors. You'd want a full blood count, UNEs to check kidney function, liver function test, definitely an HbA1c for diabetes control, and a lipid profile. Assessing and managing those risks is part of the overall picture.
So duplex ultrasound often first for imaging, angiography maybe later for planning interventions.
Right.
We've got the diagnosis. How do we manage CLI in the UK? What's the approach?
The goals are pretty clear. Improve blood flow, relieve the symptoms, stop it getting worse, and prevent those nasty complications. It's got to be a multi-pronged approach.
Starting with lifestyle.
Absolutely fundamental. Smoking cessation is number one. It's probably the single most important thing a patient can do. Huge impact.
Is it stress that enough?
Then regular exercise. Even though it causes pain initially, structured, supervised exercise programs are really effective. And of course, a healthy, balanced diet, good for the whole cardiovascular system.
Okay, lifestyle first. What about medications?
Meds are crucial too. Usually patients will be on an antiplatelet agent like low-dose aspirin or clopidogrel to make the blood less sticky and reduce clot risk.
Standard for vascular disease.
Exactly. And a statin is almost always indicated for lowering cholesterol, but also for those other beneficial pleiotropic effects on the vessel wall, like reducing inflammation.
Okay, antiplatelet, statin, anything else?
Vasodilators are sometimes used, but honestly, the evidence for them making a huge difference in established CLI is a bit limited. Much more important is managing other risks, so tight blood pressure control with antihypertensives if needed, and really good glycemic control if the patient has diabetes.
So it's aggressive risk factor management across the board.
That's the key. Target everything you can modify.
You mentioned supervised exercise earlier. Why supervised specifically?
Good question. Supervised programs really help patients push themselves safely, improving walking distance and quality of life. They encourage the body to develop collateral circulation, like natural bypasses around the blockages.
Interesting. And if these conservative measures aren't enough?
If symptoms persist despite good medical management and exercise, or if the CLI is critical, meaning rest pain, ulcers, gangrene, then referral to a vascular surgical team is necessary to consider revascularization.
Meaning procedures to restore blood flow.
Yes, things like angioplasty, stenting, or bypass surgery. There's also a medication called naftidrafuryl oxalate, which is licensed for intermittent claudication and can be an option for some patients who aren't going for or aren't suitable for intervention.
Right, so there are medical and potentially surgical options. What's the overall prognosis like for someone with CLI?
It really varies, depends heavily on how severe the blockages are, what other health problems the patient has, like heart disease or diabetes, and critically, how well they engage with treatment and lifestyle changes.
So it can be improved.
Definitely. With timely diagnosis and good management, many patients see significant improvement in their symptoms, better quality of life, and a lower risk of complications.
But the outlook isn't always positive.
Unfortunately, no. In severe advanced cases, especially with extensive tissue damage or gangrene that can't be reversed by restoring blood flow, amputation of the limb might be the only option to control pain and infection.
A very serious outcome.
Yeah.
Which brings us to complications. What are the main things we're trying to avoid?
There are several major ones. Those non-healing wounds or ulcers are a big problem. Painful, hard to treat, high risk of infection.
Makes sense, and tissue starts with blood.
Exactly. Then there's tissue necrosis or gangrene, which we mentioned, actual tissue death. Infection is a major risk in ischemic tissue. It can spread rapidly and become limb-threatening or even life-threatening sepsis.
Okay. Wounds, gangrene, infection. What else?
A really important one. CLI is a marker of widespread atherosclerosis, so these patients have a much higher risk of heart attack and stroke. It's not just about the leg.
Systemic disease.
Absolutely. And finally, the impact on daily life, the pain, the difficulty walking, leads to significantly impaired mobility and reduced quality of life.
There's a mnemonic for those too, isn't there?
Yes, a handy one is WFH. W for wounds, non-healing, I for infection, T for tissue necrosis, gangrene, C for cardiovascular risk, heart attack, stroke, and H for hindered mobility.
WFH. Wounds, infection, tissue necrosis, cardiovascular risk, hindered mobility. Good one to remember. Okay, so wrapping up, it's clear chronic limb ischemia is a significant condition. You need a solid grasp of it for clinical practice and, of course, for the MSRA.
Definitely. Recognizing those risk factors using things like SAD-HOF, understanding the presentation from claudication to rest pain, knowing the importance of the ABPI, it's all key.
And remembering that management is multifaceted lifestyle, LEDs, exercise, and sometimes surgery.
Couldn't agree more. And perhaps a final thought for you listening. While we focus a lot on the medical side, think about those lifestyle changes. They seem simple, but they can profoundly affect long-term outcomes in CLI.
That's a great point.
What do you think are the biggest barriers patients face in making those changes, quitting smoking, exercising regularly? And how can we, as healthcare professionals, actually provide better, more effective support to help them overcome those barriers?
Something really important to consider in practice. Now, if you want to dive deeper into MSRA revision and test yourself with practice questions, do head over to PassTheMSRA.com.
And for a wealth of free MSRA preparation resources, make sure you check out freemsra.com.